Thank you, Bob. Thanks for the opportunity to speak to you. As Bob mentioned, we'll be talking about the TASP cohort, which I really think of as a second-generation data collection system in BC. We've been collecting population-level data on clinical outcomes and treatment in BC since before the hard era began. And it's really become the core, I believe it's been one of the key factors in the success that we've had to date. And this is really the next step in what we're doing. It was the formation of this data set of our new data collection system was the observation of the secondary preventive benefits of HART, which spurred on the Stop HIV/AIDS pilot project, which was a broad partnership between a number of agencies across the province. The CFE, the Center for Excellence, was tasked with monitoring and evaluating the program and its outcomes. And for us to do that, it required comprehensive provincial clinical and health administrative database linkage. So that was the rationale for putting together the data set. And once the pilot was complete, it led to province-wide uptake in April of 2013. So this was, I put together a couple of slides on process because I realized in a lot of other jurisdictions, and this came up in our discussions on the IAPAC Cascade of Care Guidelines. A lot of other jurisdictions don't have the same type of data infrastructure. This is, to tell you, if you are putting together linked data systems, you should go in with your eyes wide open because it's quite a difficult process. So it required partnership of a number of different data stewards, and the timelines were quite long. This process was initiated long before I joined the center. Initial discussions were in 2004. We finally initiated the request in 2010 and received our first batch of data in 2012. So that 2-year period is actually relatively fast given the complexity of the data systems being put together. And you can see this is a collection of 9 individual data sets, each of them with a population level scope. It's one of the advantages we have with having a universal healthcare system is we have population level data collection. I should tell you that each of these distinct databases are quite mature. Most of them were developed in the earlier mid-90s, and they've just, only in 2012 have they all been put together in a single data set. So, a lot of time and effort has been put into managing these data sets, cleaning them, and ensuring they're producing adequate capture and adequate representation of whatever they're capturing. And so this is another schematic of how this data set was put together across the 4 different groups of data stewards. An intermediary was used to take in the identifiable information, strip it of identifiers, and deliver it to us at the center, de-identified. This took a lot of time, and depending on your privacy and privacy legislation, it's going to be a complicated process to put something together. And just to further drive home this point, I'm not going to go through this slide line by line, but this is just a schematic that our data people have to keep them on track of what has to happen every time data is updated. So this gives you an idea of the complexity there. Once we collected the data, we knew everybody with a nominal identifiable HIV test was a confirmed case. We know everybody with antiretroviral drug dispensation and detectable viral load was a confirmed HIV case. However, we had a large group of clients who received HIV-related services that were identified within the other data sets that we had to make some decisions about. We applied some case-finding algorithms to determine who was and wasn't an HIV case. So you can see we started, the full group was about 25,000 right up at the top here. We separated that into confirmed and unconfirmed cases. We use case-finding algorithms. We validated them. In this case, we found that individuals with at least 3 HIV-related physician visits or an HIV-related hospitalization should be classified as HIV positive, and these individuals were included into our cohort. So not only are we collecting more data on the HIV positive individuals that we know of, it's actually a larger cohort that we're studying, some of which, some of these patients that we've never seen before. So we have a number of descriptive information. With information from the CDC, we have a lot more, we have a better grasp of how our risk groups break down, both individuals accessing treatment or not, although it's probably straightforward. So when we approach the use of a large administrative data set, the first question I ask is, how do we maximize the public health value of the data set? And the first thing we thought to do was to populate the cascade of HIV care. I'm not going to go into it with too much detail. We talked about it last year, but basically with a large linked data set like this, we can, rather than produce a cascade based on estimates from the peer-reviewed literature, every step after the infected stage is actually populated with true data, true individual level data. And not only that, we're able to do sensitivity analyses on our definitions. So, I want to point out viral suppression in particular. We've used a more stringent threshold than most people use in the literature. We've considered an individual virally suppressed in a given year if they have a 3-month episode of suppression, which is at least 2 viral loads under 50 over a 3-month period. And you can see that's the red line. If you use just a single viral load in a calendar year, a single suppressed viral load in a calendar year to indicate viral suppression, you can see it's a very big difference. So it's one thing to consider when you're comparing cascades. We've used a lot of this information and compiled it in a quarterly HIV surveillance report, which we produce not only for the province, but for each of the health authorities within the province. And we've, the cascade is a feature in the quarterly report, but we've also included a number of other quality of care indicators, such as the programmatic compliance score, which Viviane Lima devised. And critically, aside from having these cascades for the different health authorities, we've stratified by a number of key demographic and risk group variables. And you can see in this group, this is for Vancouver Coastal, you can see our focus needs to be on individuals under 30 years old. And this quarterly report was developed collaboratively with input from all of our partners, and we've described the content and methodology in an upcoming article from Lily and Lorenko. Aside from that, the database has allowed us to do a lot of longitudinal studies on clinical progression, on health service resource utilization. It's informed our economic evaluations for heart scale-up and moving forward. So, the first thing we looked at was CD4 progression while on heart, and we found great improvements at the population level. We also looked at drug costs and the changing costs of highly active antiretroviral therapy. You can see on the right-hand panel, the costs of heart are highest among pre-heart era initiators, which probably isn't surprising. They're likely on multi-drug regimens, second, third-line regimens. And in the left panel, you see the proportion of this population comprising of the total is decreasing. So that makes us hopeful moving forward in terms of our total drug budget. And it also makes us think about the potential impact of generic medications. It's important, this is an important context in this time when, we're discussing with our pharmacare budget where we're moving forward, and they're telling us they want to cut the overall drug budget. So it's about sustainability of our efforts. We also looked at costs of non-heart health resource utilization, how that's changed over time. Probably not all that surprising or particularly interesting. We know that late-stage patients with late-stage HIV incur much higher costs, and of course, providing access to treatment will keep people out of that stage for as long as possible. And all this information, including a number of other factors that we haven't discussed, has been synthesized in an economic evaluation, which, as the first step we've used to evaluate the cost effectiveness of heart scale-up in the heart era, but we're going to use in prospective studies, not only at the population level, but within different risk groups. In addition, it's allowed us to do some interesting longitudinal assessments of complementary healthcare service on the continuity or fragmentation of care. So in this case, we've looked at the effect of OST exposure, opioid substitution treatment, on heart adherence, taking into account that OST may influence heart adherence, but heart adherence may also have an impact on subsequent OST exposure. So we've dealt with this circularity with a marginal structural model, and we found that the odds of heart adherence following OST exposure was about double, so was about 2. So OST exposure doubles your likelihood of heart adherence, which is an important finding, I think. Of course, like any database, secondary collection of data, there are limitations. We have non-nominal HIV testing in this province, so we don't have linked HIV tests. Of course, we have in-migration as well, so anybody who's migrated into the province, we won't have a linked HIV test for. We have incomplete capture of CD4 testing results, although it's quite good. Incomplete capture of emergency department admissions. We don't have complete capture of course, behavioral data, drug use for the entire population, sexual risk behavior, although we can link our data set to our various prospective cohort studies. Administrative loss to follow-up, of course, we don't observe out-migration, so we have to make assumptions on that basis. And we have an underdeveloped knowledge base for HIV prevalence. So I mentioned way back when we talked about the cascade, we looked at the different stages, and we were able to estimate with quite a lot of precision individuals from the diagnosed stage on downward. But that initial step, HIV infected, we rely on information from a national estimate, which we really don't know how accurate it can be. We think it can be more accurate, and we would like to do more prospective and targeted epidemiological studies to determine undiagnosed prevalence across the regions and risk groups. And next steps, well, there's still a lot to do. I think we're just scraping the surface of what we can do with this data set. So we want to emphasize further on quality of care, although we're already doing quite a lot of that with the cascade and with the programmatic compliance score. We can look at hospital readmission and clinical guideline compliance. A hot topic right now in the literature is churn and heart retention. We have a lot of individuals coming on and off of heart. We want to look at that more carefully, and I think we can do that by considering heart retention as a recurrent event process and using some of the unique methods in that literature to inform what we can do to improve outcomes in that area. Economic modeling to inform resource allocation decisions along the cascade of HIV care. So, I love the cascade. It's a simple tool. I think it's going to inform surveillance efforts, but it's also going to inform resource allocation decisions. And I think we can integrate the two methods to really target how we need to spend our money to solve this problem. And last but not least, and we can use this, because we have this comprehensive automated data collection system, the cost of collecting data to evaluate the impact of implementation studies decreases dramatically, right? If you can do a large-scale implementation study, and if you're not having to collect information alongside, if it's all automated, that decreases the cost of doing it considerably. So it's a great resource that we have, and we have an upcoming intervention to scale up HIV care and opioid substitution treatment facilities that will serve as a demonstration of this. So I have a lot of people to acknowledge. Hopefully I've covered most of everybody there. This is a large group effort, and we're all committed to seeing the end of AIDS and to decreasing HIV incidence in this province. So thank you very much for your time.